We now are going to head to the Eastern Cape, and I can invite my colleague, Ms. Mshweshwe, to come and give us a presentation looking into the management of malnutrition.
Good morning, colleagues. I am Nonkuleko. I'm Nonkuleko Mica Mshweshwe from the Nelson Mandela Bay District in the Eastern Cape. And I'm going to be reflecting on my experiences in the investigation that I had on the management of malnutrition at primary and secondary care levels. This is Nelson Mandela Health District. It is one of the 8 metropolitan municipalities in South Africa, and it resides at the shore of the Algoa Bay in the Eastern Cape province. We have there 1.2 million people, that is our population. And it is worth noting that within the period 2010 to 2015, the number of deliveries decreased from 21,498 in 2010 to 19,900 in 2015. And the under 5 population in our district is standing at 92,708. What was the problem that I identified, and why was it important? I think my colleague from KZN indicated that we have a problem of severe acute malnutrition in our districts. So this is what I identified, that children were dying of malnutrition, and they were not identified early in our primary health care facilities. So I had to dig and see what was happening. And those that were admitted in our hospitals, they would die within 48 hours of admission. So I had to also dig in and see what was the problem with the referral pathway. So it was important for me to dig so that I can identify gaps and so that we can employ some remedial action. And my target population was children under 5 years. What did you do to address this problem? We initially thought that it was important for us to audit nutritional assessment tools, your scales. You might have a scale, but you must make sure that your scale is functional. It is available and functional. And you also look at issues of height measures or length measuring tools, your availability of mid-upper arm circumference tapes at the facilities, and ordinary tapes so that you can check the head circumference of children. And also it was important to look at the skills of professional nurses that were seeing these children. When you talk of skills, we are going back to the basics. When you weigh a child that is under 2 years, it is important that the child is weighed naked. You know, those little things, it was important for us to see that they are happening. And those that are over 2 years, you make sure that they are weighed with minimal clothing. We also established a forum, Child Health Forum, which we called PANASA, and we made sure that in that meeting, SAM or malnutrition becomes a standing item on the agenda so that we can motivate staff. And then we also created those malnutrition intersectoral forums where we will have other clinicians, not just the professional nurses, your dietitians, your social workers, the multidisciplinary team. For me, it was important that we undertake a retrospective review of the malnutrition records. All the deaths, they knew in the hospitals that they must put them aside and we are going to come and audit them, because we wanted to look at the management of the inpatient with malnutrition. Auditing of road to health booklets at the primary health care facilities. This was very important for us so that we can develop quality improvement plans and implement them as such. Now, these are the results of our initial project, where we actually thought that we identified a cluster where these malnutritions were happening. And in that cluster, we identified 2 clinics. And we looked at the head count of those clinics, and we took 10% of the head count. In one clinic, we took 50, and in the other one, 49, because they were having plus minus 500 per month. That was their average, and the average of the other clinic was 490. So that was 99. So briefly, those are the results as they are reflected there. Those are the things that were not done in percentages. The child development, it was not done in 35% of one clinic and 28% of the other clinic. Head circumference, we know that at 14 weeks and at 12 months, we need to do that head circumference. But if the child is HIV positive, we do it frequently at 3-monthly intervals. And 49% in one clinic, it was not done, and 64% in the other clinic. I will not go through all the results, but also the problem that we had was the length for age that was not being done. 63% in one clinic and 78% in the other clinic. Also, what we noted was the birth, the weight that was not plotted at birth. That means our delivery facilities were not plotting the weight, and immediately I contacted my ADM, the advanced midwife in our team, and she drew an SOP, for them at the delivery center so that they can start, as much as they write the weight, but they don't plot it, so they can start plotting that weight. I also made it important for me to actually go to the institutions when we audit the charts. I'm not going to run through all the audit. I'm just going to identify the areas of interest. Duration of patient that they spent in OPD or casualty. It remained more than 2 hours, and that is a problem. If a child is going to stay there for more than 2 hours without feeds, it becomes a problem because the child is going to be hypothermic and hypoglycemic. So this is what we noted. Out of the 7 charts, all 7 children spent more than 2 hours at the OPD without being fed. And also none of the children, unfortunately one of the children there, because you see that 6, one of them was nil per os, so that one was not going to be fed. None of the 6 were fed within the first hour. Some children with blood sugar tested on admission. Also, they were testing that. We noted that at least 6 of those children were tested on admission. So that is the report, because I'm struggling to get there, but I think you can reflect. Also, the feeding, children fed 3 hourly. Only 50% of children were fed 3 hourly. They were skipping some feeds in between. They were skipping the feeds. Also, I looked at the charting of input and output, which was very important for us. They were charting. If you look, is the child having intake and output chart? The chart was there. But there was, in the intake and output chart that they were using, there was no space to write the target amount to be taken. But they will write that the child has been fed. Amount actually taken, also it was written, but they will not tell you what is the amount that was left over. I'm just going to quickly share the tools. This is the tool that I used for the inpatient management of malnutrition. So I didn't go through all the elements there. And this is the tool that we are using now. We developed with my pediatrician, Dr. Makubalo. We developed another tool because we thought that this tool would be very sensitive in terms of identifying all the gaps in these children at the clinic level. What new practices or ideas did you use? We started doing action research strategy. Action research was important because as DCSTs, our responsibility anyway is supporting, mentoring, and training. So if you go to the clinic and find some gaps, you don't say, I'm doing research. You have to go and correct it immediately. So it is about doing research and taking action at the same time. We got a lot of support from the managers, especially the nutrition managers. The nutrition managers worked with us in this project, and colleagues like in the DCST team. The difficulties that we encountered, staff attritions and rotation of staff. In our clinics, they spend 3 months in the area and they rotate within the clinic. And then also we established breastfeeding support groups, but they were not sustainable. After 6 months, you'll find that we have to go back and establish another one because that one has dissolved. Could the practice be scaled up? Yes. The operational managers, we said they must audit at least 5 road health booklets per week. It was important that they take over the project. And then they can also have some peer reviews where in the cluster they can exchange one clinic review or audit the other clinic. Audit tool that talks to plotting, the one that I've just shown, very important, that because it talks to plotting, connection of dots, interpretation of graphs, and the appropriate interventions. That's a problem. Sometimes they do plot, but they will not intervene. You find that the intervention that has been taken is not appropriate. So we also monitored that. And then there are more tapes to be made available in the early child development centers. That was very important that we do that. And then also community IMCI for our healthcare workers. Gradual improvement in the plotting practices has been noted in our district, and also available in functional nutritional assessment tools in all our facilities. We make sure that our tools are functioning. We need to make sure that they calibrate all the scales before they actually do the weight. Intersectoral collaboration. F75 was made available now in our OPDs and casualties. Audit of SEM deaths in hospital, they had to have teams in the hospital so that in our absence they can also do the auditing. It must continue. Improvement in the indicators. There is this improvement. Now when we started, we were at 18. That was the first quarter, 2014, 2015. And in the first quarter now, in 2015, 2016, we are at 4.2. So there was some impact that this created. Is there anything you would have done differently? Communicate and work smart. Communication, communication, communication. We need to involve more people so that they can assist us. And also you must use more data. Like now, we're talking about the outcomes, but we need to use our data. Importance of multi-sectoral linkages, which have been indicated in this room, and importance of making sure that the caregiver is conversant with the road to health card. Our caregivers must be conversant with the road to health card. And in conclusion, I want to say that in the absence of indicators, audit tools assist to assess quality of care at hospitals and primary health care levels, and facilitate the development of quality improvement plans because they are very important. After you audit, it is important that you develop a quality improvement plan. Interventions are required at multiple levels, that is your PHC, your hospital, and your community. Thank you very much.